Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of a rare entity, but is an important differential diagnosis, which is malignant peritoneal mesothelioma. So this is a case of an 82-year-old female patient who presented with abdominal pain and distension and was found to have omental nodules. And the first thing that would come to mind is that this is probably a female genital tract, in particularly ovarian tumor, widespread metastatic to the omentum and or to the peritoneum. And on low power magnification, the tumor is pink in color, as you can see. And really, carcinoma stays an important top in the differential diagnosis. Now, zooming into high power magnification, the tumor cells have abundant acidophilic cytoplasm, large voluminous acidophilic cytoplasm, vesicular nucleus, very prominent nucleolus. And still at this stage, probably mesothelioma would not be that diagnosis that would come in mind. But remember, an excellent clue to the possibility of the diagnosis is the voluminous acidophilic cytoplasm. This is another area where the tumor cells show here more in the way of pleomorphism, very atypical nuclei, very prominent nucleoli, and then some of the tumor cells have this evacuated cytoplasm, and you start to wonder, could this be, for example, an unusual type of liposarcoma, or again, metastatic carcinoma remains in the differential diagnosis. And again, on another field where we have cells with acidophilic voluminous cytoplasm with a vesicular nucleus and a prominent nucleolus. And perhaps here where you start to think, could this be malignant mesothelioma? And I think an area like this, a focus like this, one should really entertain the differential diagnosis of malignant mesothelioma because of the appearance of the tumor cells, where they have abundant acidophilic cytoplasm, and then the relatively bland looking monomorphic nuclei and the prominent nucleolus. I think this is among the first fields that would make one think about malignant mesothelioma. And here we start also to think about malignant mesothelioma. Imagine that those cells would exfoliate into the cytology and acidic fluid is examined. Definitely malignant mesothelioma would come into the diagnosis, differential diagnosis. We have even here the ruffled surface cytoplasm and surface processes that are very similar to what we see in cytology. And this is one atypical mitosis that would support this is a malignant process. There is an area of necrosis as well, and some myxoidish degeneration with some hop nailing, which would again bring into the differential diagnosis serous carcinoma, in particular, whether of the ovary or a primary peritoneal, and more solid sheets of the tumor cells. Definitely still carcinoma is probably at the top of the differential diagnosis, but we have to think of mesothelioma at this stage. And calretinin was beautifully positive in the tumor cells. Remember that calretinin has to show cytoplasmic and nuclear staining in order to interpret the case or the stain as positive in the presence of an internal negative control. This is a blood vessel. Remember also that calretinin can show sometimes positivity in some of the types of carcinoma. So this is not entirely specific, although its sensitivity is almost 100% for mesothelioma. And this is the area where we have the cells with the voluminous cytoplasm. And as you can see here, the cytoplasm is positive as well as the nucleus, which would be interpreted as positive staining. Also, bodoplanin or D240 is another important marker that would support the diagnosis of mesothelioma. Again, alone is not entirely specific. However, the sensitivity is in the range of 80 to 90%, and usually we see membranous positivity, and here beautiful positivity, even the large cells and the smaller cells. Another marker that is extremely important, perhaps, however, the least sensitive and specific is the WT1, where we see the nuclear staining in the tumor cells. However, remember that WT1 can be positive in ovarian serous carcinoma as well as P53. This case is strongly positive, so the presence of P53 positivity, WT1 positivity is common in malignant mesothelioma. However, these are also so common in ovarian serous carcinoma, and alone cannot really 100% rule out the diagnosis of carcinoma. So how can we rule out the diagnosis of carcinoma? We need epithelial marker, something like BER-IP4, which is completely negative in this case, as well as PAX8. Luckily, it was negative in this case. However, remember that something like 6 to 10% of cases of mesothelioma, including peritoneal mesothelioma, can be PAX8 positive. So again, not a single marker is entirely specific or sensitive to render the diagnosis of mesothelioma. You have to work in panels. You have to order a panel of immunostain where you have at least 2 markers that would support or rule out the diagnosis of mesothelioma, and at least 2 markers for epithelial tumors. So the final diagnosis in this case is malignant peritoneal mesothelioma. This is a quite rare diagnosis, much rarer than pleural mesothelioma. However, malignant peritoneal mesothelioma is more common in females. It does not have the same association with asbestos exposure as in the case with the pleural malignant mesothelioma. Remember that it's usually a pink cytoplasm, and it brings into the differential diagnosis a large variety of tumors, in particular in females. We have to think about female genital tract tumor, in particular serous carcinoma of the ovary and or peritoneum. Remember that there isn't a single immunohistochemical marker that is entirely specific or sensitive. You have to work in a panel of immunohistochemical markers in order to render a confident diagnosis. In the caption, I have a link for a beautiful article that discusses a large number of malignant peritoneal mesotheliomas, including how to best utilize immunohistochemistry in order to render the diagnosis. I hope you find this tip useful in your daily practice. Thank you.